we can reshare again shortly, or to email the state directly, and we can share that information as well. So I thank you all for joining us today. And with that, I am going to pass things along to Katie, the Director of Rehab Services, who will take us through the start of the presentation this morning.
Thank you, Meg. Next slide. Hi, this is Katie Merrill. I'm from the Office of Mental Health, Director of Rehabilitation Services, and I'm joined today by Steve Vroman, who's also in our Rehab Services unit, and Danielle Olson from OASAS. And we're going to talk about psychosocial rehabilitation and what that service looks like under CORE. So we're going to begin by introducing the service definitions and components and highlighting what some of those changes are from BH HCBS to CORE. We're going to talk about the staff and supervisory qualifications and training requirements for PSR staff and supervisors. And I'm going to just offer some brief highlights on the programmatic changes from BH HCBS to CORE services, all of the details of which can be found in the operations manual and in the benefit and billing guidance that I linked in the chat box. Next slide. So first, I just want to talk about why we're making these changes. We know that BH HCBS had a lot of strengths and a lot of weaknesses. We've gone out and met with many providers over the last 5 or so years, both in the context of technical assistance, and we've also done a fair amount of oversight and monitoring visits where we've gotten into the charts, we've interviewed clients and staff, and we've learned a lot more about what these services look like on the ground and what they look like when they're done well. And we wanted to share that information. So the operations manual is based on the years of experience that we now have in the delivery of these services, in looking at what a la carte community-based service provision can be at its best, and in how we can prevent some of the issues that we've had in the past. So you'll see that the language and the definition and components has been updated to really reflect what these services look like on the ground. And we wanted to offer more descriptive language in the components so that staff and supervisors have a good idea of what the interventions are supposed to look like and how you might document them. So we hope that the language in the manual is helpful for you as you think about that concept of the golden thread of medical necessity in your documentation, and as you engage in service planning and really thinking about how these services can support individuals with behavioral health disorders in achieving recovery. Next slide. So the next couple of slides, I'm going to go through some really high level changes that were made, and then we're going to dive into the details with Steve in just a couple of slides. So just to get us started, I want to emphasize that psychosocial rehabilitation can now encompass a full range of life role goals. So whether someone wants to focus on where they live, work, learn, or socialize, PSR can do it. So it's really a very broad service. There is still the opportunity to offer group services under PSR, which existed under BH HCBS, but now we want to emphasize that you can also do groups to support work and school related goals. So if you have a couple of individuals that you're supporting who are perhaps starting trade school or a community college in the fall, you might decide to offer a group that summer to help people prepare and work on time management skills or study skills. And we see that as a really big opportunity. We did eliminate the annual hours cap, as well as the daily unit limit. So utilization of these services is going to be driven by the person-centered ISP and really conversations with the person around what they need and what they would prefer. We also eliminated caseload caps. So under BH HCBS, the current requirement is 20 clients to 1 staff. And so what we've done instead is we've put clinical supervision in place, and we have put in the requirement that the clinical supervisor can determine what an appropriate caseload looks like. And that really might vary by staff. Some staff people may have a very intense caseload and they may only want to have 5 or 10 cases because the utilization is very high. Others may have an easier caseload, people who only need like a half hour to an hour a week of check-ins, and they may be able to carry a higher caseload. So that's going to allow for some supervisory discretion. We have aligned the minimum service durations across all core services. So not specific to PSR, but all 4 core services have a 15-minute unit. We have clearly defined our expectations around clinical supervision, including who can provide it, what it means to provide clinical supervision, and we've recommended some best practices around the frequency of that supervision. We also have an allowance for administrative or task supervision in addition to clinical supervision. And we're going to talk a little bit more about what that looks like later in the presentation. Next slide. When you look at the definition and components for PSR, you're going to see that they look very different from how they looked under BH HCBS. And that's not because what staff are doing has changed dramatically. It's just because we've found better language to describe what we intended. So psychiatric rehabilitation is really the philosophy behind PSR. And the idea is that we want to help individuals choose, get, and keep valued life roles in the settings where they live, work, learn, and socialize. PSR is all about person in environment. And that's why it's such a great fit for core services where everything is provided in home and community-based settings, with a couple of exceptions that we'll talk about later. We also added a person-centered planning, documentation, and collaboration component. It's the very first component listed under PSR in the operations manual. And what we like about this piece is that it really outlines the billable interventions you might provide around service planning, measuring progress, collaborative or concurrent documentation that's done with the individual, and communication and coordination with collaterals, including outside service providers. So if you are routinely talking with family members who have been identified by the individual as important in their recovery, if you're collaborating with a housing provider or an outpatient clinic provider that the individual identified, that time could potentially be billable under PSR. And we hope that that contributes to the sustainability of these services and integrated care. We've made some changes in how the services are accessed, and we hope that this promotes upfront engagement of the individual. So as many of you who have been to our previous webinars know, there's no longer a New York State eligibility assessment that's required prior to making a referral. And referrals don't need to just come in from care managers and recovery coordinators. Those will remain an important referral source, but it's not the only referral source. We want to allow for self-referral, for referrals from family or friends, from housing providers and clinics. So we've made those changes that will allow those referrals to come in from just about anywhere. And it'll allow for that upfront engagement where the person can meet with the PSR provider directly and decide if the service is right for them. We also added some interventions that will support vocational and educational goals through psychosocial rehabilitation. And so as you read through the details of every component, we give a lot of examples of what interventions might look like. And we've called out some specific ones that you might do to support work and school goals. For example, you might help connect someone with a benefits counselor. You might support them in increasing their study skills or their time management skills so that they could be successful in a school or work environment. So we've really called a lot of those out, and we're going to talk about that in more detail over the next few slides. So next slide. With that, I'm going to turn it over to Steve Roman to talk about some of the details.
Okay, good morning, everyone. Thank you, Katie. This is Steve Roman from OMH Central Office. Next slide, please. So we're going to start off talking about the service definition for PSR. So before I start, I just like to say that this section is kind of an overview of the service. It's we're trying to highlight the service components, interventions, things like that. But I would really encourage people to spend some time in the operations manual. Much more information contained there. But so let's start out with the service definition first. PSR is designed to assist an individual in improving their functional abilities to the greatest degree possible in settings where they live, work, learn, and socialize. So you're going to hear that a lot throughout this presentation. Rehab counseling, skill building, and psychoeducational interventions provided through PSR are used to support attainment of person-centered recovery goals and valued life role goals. So again, we're starting to get into the service components here. Approaches are intended to develop skills and overcome barriers. So that's really important to understand. that the interventions, the approaches that you use as a practitioner, what you're really trying to do is develop skills and overcome barriers for a person's behavioral health disorder, and you're really trying to promote independence and full community participation. Next slide, please. So here we have the three components of PSR: person-centered assessment, recovery planning, documentation, and collaboration. So this is just briefly a process that is used to support an individual's recovery goal. So this is some of the work that you start doing as part of the engagement process. When someone comes into your program, you're doing that person-centered assessment. You're doing recovery planning. So that's kind of the first part. The second component is individual psychoeducation and skill building. So these are interventions designed to develop or improve personal coping strategies, prevent crisis, and promote recovery. And the third component of PSR is rehab counseling. So these are individualized, goal-driven interventions that facilitate, promote, and improve functioning in those four domains: again, living, working, learning, and social environments. Next slide, please. So we're going to take some time now to kind of do a little bit of a deeper dive into each of those service components. And as I said, this is very much an overview. So I think it's going to be important to spend some time in the operations manual, just to make sure, just to make sure you understand. But for the purposes of this presentation, we just wanted to kind of give you a sense of what's involved in these service components. So the assessment, recovery planning, documentation, and collaboration, that's working with the person to identify recovery goals. What are their strengths? What are their supports? What are their mental health barriers? So very important work as you start working with someone, you start that engagement process. Another component is the service plan, the ISP development, doing progress notes, checking on doing assessment. You're always doing assessment when you're working with people. You're always assessing for progress towards goals. Lastly, another component would be communication with collaterals, including other providers, to ensure that the services are integrated, you're working together, it's collaborative, and you're helping someone to access their supports and resources. Next slide, please. So the next component here, individual psychoeducation and skill building. This is a good chunk of the work you're going to do as part of a PSR practitioner. So you're doing psychoeducation around disability, co-occurring disorders, coping skills and stress reduction, time management, problem-solving skills training, medication education and self-management skills training, crisis prevention planning. These are just a couple examples of sort of the interventions that fall under this component. So again, psychoeducation and skill building, you're giving people the knowledge that they need around their disability, you're teaching coping skills and stress management training. So education and skill building, very important components. Next slide, please. Lastly, we're going to spend some time talking about rehab counseling. So this is very much rooted in psych rehab practices. If you're not really familiar with what that means, there's tons of great training resources out there we can link you to. But under rehab counseling, some of the components, some of the work you're going to be doing, which is very important. Identification of strengths and resources which may aid the individual in achieving recovery. So right from that intake, right from that the first time you start working with people, you want to help them to identify what are their strengths, what are their resources you can leverage. You want to support the individual's personal development, their work in academic performance, and their functioning in social environments. So again, what are their strengths and resources in those four domains? What does that person bring that you can help them to learn those skills? Another component, resource and support coordination to help an individual identify, assess, develop, and secure available supports. Part of your work is going to be supporting someone to identify and secure those supports in the community. So what is available to that person that can help them with their life role goals? Identification of personal, environmental, and behavioral health barriers that may impede the development of skills necessary for functioning. So you're going to hear that a lot. You're going to hear about skill development, resource coordination, and barriers. So really the work that you're going to be doing with someone is helping them to develop the skills to overcome these behavioral health barriers. The last component here, skill development to support interpersonal and functional skills. So that's skills like self-advocacy, system navigation. So what skills are they going to need, which will help them with their recovery and independence? Next slide, please. So again, we're going to talk some more skill development to support the individual to self-recognize emotional triggers and self-manage behaviors related to their behavioral health disorder. Skill programming to support the individual to develop step-by-step plans to use skills successfully. So skill programming is essentially someone has these skills, but how do they actually put them into play? How do they implement these skills? So that's where skill programming falls in. Cognitive remediation. Lastly on this slide, ongoing counseling, mentoring, advocacy, and support for the...
Katie, I'm not sure. Are you able to cover this? I'm still not able to hear from Steve. I'm so sorry.
Sure. Yep. I just sent him a text. He says he's logging in again. But yeah, I'll pick up until he's back on. So rehabilitation counseling, the focus is on skill development. We want the person to learn to be more independent, to recognize their triggers and self-manage behaviors. So you can use strategies like wellness self-management. You can use relapse prevention planning. We also have skill programming to help the person to develop step-by-step plans to use their skills successfully in their lives. So it's not just about learning the skill initially, but about generalizing that skill and being performing it successfully in the settings where they live, work, learn, and socialize. Cognitive remediation, which is really great for individuals with cognitive impairments as a result of behavioral health disorders. So for example, individuals with schizophrenia can really benefit from cognitive remediation to increase their executive function. We do recommend that staff have additional training in cognitive remediation before delivering an intervention at that level. And then we also offer ongoing counseling, mentoring, advocacy, and support for the purposes of sustaining an individual's success and satisfaction in their valued life role. Now, if you're at all familiar with our PROS program, you might recognize some of that language around ongoing counseling, mentoring, advocacy, and support, because that's what we do through the ORS service under PROS, which is a service dedicated to supporting people with sustaining their employment, that is sustaining work positions. So we want to make sure that under PSR, you're also able to provide that level of support to help people be successful in the settings where they live, work, learn, and socialize. All right, next slide. Okay, and next slide again. So psychosocial rehabilitation uses a person in environment approach to rehabilitation and restoration of skills. This is really important because many of our traditional mental health programs are site-based. You know, if you look at PROS or a psychosocial club or a CDT, people are coming into a site and largely receiving their services there. With PSR, you're going into people's homes, you're looking at the environmental barriers that they may be experiencing there, you're seeing what their day-to-day life looks like and how their mental illness or addiction disorder is impacting them. So with the person in environment approach, and it does look like Steve might be back. So Steve, if you are, you can cut me off.
Okay, I am back. I apologize, everyone. I'm not sure what happened. So I know we've been having a little technical issues here. So, I'm sorry, Katie, didn't mean to cut you off.
That's all right. I'll finish the slide and then we'll switch back to you. So with PSR, we have the person in environment approach to assessment and rehab counseling. What we do is we focus on restoring their functioning and skills and developing supports so that they can be independent in the settings where they live, work, learn, and socialize. We focus on those concepts of choose, get, and keep. So the person chooses a valued life role, for example, returning to school, or perhaps getting custody of their children, finding meaningful relationships and friendships. Those are all things that someone might choose to work on. Then we help them get that goal. So we identify all of the skills that they are going to need to be successful. We practice those skills, and we identify the resources and supports that someone might need. So maybe they need to be connected to AA, maybe they need to be connected to a benefits counselor, or maybe they want to join a community center where they can engage in a book club. So you help them get the resources they need, and then you help them keep that valued life role. So once they have achieved it, you want to make sure that they keep it, that they don't have a relapse. Some individuals may need or prefer specialized employment and education services to meet their goal. So at times, PSR may not be a high enough intensity for someone. They may want to receive more IPS. They may need someone who has more experience with job development or something like that. And in those cases where you feel like PSR, or the individual feels like PSR is not appropriate to meet their school and work goals, we would recommend that you refer out to a behavioral health home and community-based service, or perhaps to a state aid-funded employment service that's available throughout the community. All right, next slide, and we'll turn it back over to Steve.
All right, thank you. So we have enhanced rates to support education and employment goals. As we talked about before, PSR will now be able to support people with those goals, education and employment. 2 new rate codes have been added for PSR services delivered in support of these goals. So it is important to kind of point out PSR is not supported employment or education, but it can be a successful approach in assisting individuals with finding success in work and school environments. So something that we've talked about, PSR is intended to help people develop skills to overcome barriers. So there are some interventions that are contained within supported employment, supported education, which will not be allowable under PSR. And we're going to talk about that in a second. But again, the focus of PSR, the focus of psychoeducation or psych rehab is psychoeducation, skill building, and overcoming barriers, connection to resources. So hopefully as we go through this, this presentation today, those concepts are really going to become apparent to you. Next slide, please. So we're going to take a moment to talk about documentation. So ISPs will need to be updated to reflect core PSR goals and service components. So right now, everyone is receiving PSR under adult BH HCBS. So you will have to update your ISPs. The interventions contained on the ISPs must reflect efforts to assist with the restoration of skills development and the development of supports. So we're going to keep on really drilling on that because this language is really important in your ISPs and all of your documentation. It's really important that your staff delivering the services understand these components, understand the scope of their work. So progress notes will need to document delivery of allowable interventions under the PSR service. So again, making sure your staff know about allowable interventions, what the scope of the service is. As I said before, I'd really encourage everyone to spend some time in the operations manual. This is very much an overview, so you will see these components explained in more detail. Next slide, please. So excluded activities and interventions. I alluded that 2 slides ago. PSR is not supported employment. PSR is not supported education. As Katie had said, there are other resources out there in the community, Access VR, some of the interventions that are allowed under adult BH HCBS education and the employment services may be more appropriate for someone rather than PSR. But certain activities we may think of when supporting education and employment goals are not eligible. These include things like job coaching, job supervision, job development and placement, employment assessment and planning, negotiation with prospective employers, job analysis, training and systematic instruction, job carving, and things like in the education environment, things like note taking. So you see kind of here the theme is, these are very sort of generalized tasks, certainly very important. Job coaching is teaching someone how to perform a specific job, like packing groceries, let's say. Really PSR, again, needs to be focusing on skill development, access to resources, and overcoming mental health barriers. So these are just some examples of things which would not be allowed under PSR. Next slide, please. So qualifications and trainings, this is really very well outlined in the operations manual as well, but we did want to take some time to review the qualifications and trainings for PSR. Next slide, please. So staff and supervisor quals. In order to deliver PSR, it's an unlicensed behavioral health staff. What that means is 1 to 3 years of experience in behavioral health, or a bachelor's degree, or a certified peer. So what's actually very nice is that the staff qualified for PSR will also be qualified for family support. And if you're a certified peer, you're qualified for peer support, PSR, and family support. So we've tried very much with CORE to align staff qualifications across the services. Clinical supervision, this is something we've talked about a lot in our monthly provider forums, but the qualified staff for clinical supervision, CRC, KSAC, LCAT, generally these are all the licensed practitioners, licensed professionals, psychoanalysts, psychologists, marriage and family therapists, LMHC, nurse practitioner, psychiatrist, physician, physician's assistant. So you see the list there. We've also talked about in our trainings before, there's an opportunity for administrative or task supervision. So this is very much your day-to-day kind of supervision with folks. So we have CORE does allow for this 2-tier supervision structure, where there is that task supervision and administrative, which again is very much your day-to-day supervision, caseload management, things like that. And then there is that opportunity for clinical supervision as well. Next slide, please. So just a minute to talk about trainings. Those of you that are HCBS providers already know our trainings are contained in the Center for Practice Innovation Learning Management System. Much like HCBS, there are core, we're calling them essential knowledge areas, essential competencies. So there's 6 required modules for all core PSR staff and supervisors. Psych rehab, person-centered planning, motivational interviewing, shared decision-making, trauma-informed approach, and wellness self-management. So some of these overlap with HCBS training requirements. So if you or as a supervisor or your staff have taken these trainings under HCBS, they will qualify under CORE. So that will lessen the training requirements for current providers. So again, these are our essential knowledge areas that everyone is going to need to take for the core services. Next slide, please. So there are also service-specific trainings. So for PSR, what we have is an application of principles training, and that is really very much, what does this service look like on the ground? What are the competencies that you as a staff person need in order to deliver these services? And there's some great case examples, just kind of, it's a good sort of toolbox approach. What needs to be in your toolbox? What skills do you need to have in order to be a competent PSR practitioner? So that is the training requirement, the sort of general training requirement for PSR. Next slide, please. And there are also specific training requirements for providing the PSR plus employment and or PSR plus education. So as we talked about earlier, PSR plus employment or education does allow you to bill at an enhanced rate. So the trainings for this, we have PSR, Psychosocial Rehabilitation, with an educational focus, and there's 2 modules: using PSR to support education goals and IPS supported education. And again, all of these are going to be in the CPI learning management system. For PSR with an employment focus, we have a few trainings as well. So using PSR to support employment goals, employment and benefits 101. So again, thinking about that toolbox concept, this is going to be really important for you as a staff person, or if you're a supervisor, really important for your staff to understand. It's just a general overview of things you should know when you're helping someone with employment. Just understanding basic concepts of employment and benefits. You know, certainly over the years, we've all heard folks that are reluctant to pursue employment because they're afraid it's going to affect their Social Security or other benefits. So this talks about that. The last part of the PSR training with employment is IPS, Introduction to IPS, the Individual Placement and Support Model of Supported Employment. So really our goal with these 2 trainings was to really help staff understand what they need to do on the ground and how you can really support folks with education or employment goals. Next slide, please. And now I am going to turn it back over to Katie to discuss service delivery.
Thanks, Steve. All right, next slide. So PSR services should be delivered in the location of an individual's choosing, which means that we should be honoring their preferences around days, times, modalities, and where you're meeting with them, whether that's at home, at a community location, or in some circumstances in an office or site-based location. PSR can be provided one-on-one, in a group, and via telehealth or telepractice. As of right now, we are working under the COVID telehealth flexibility. And as soon as we have emergency regulations in place that would allow for PSR long-term through telehealth, we will let you know that. But for right now, we're working under the COVID flexibilities that allowed for telehealth. Group sizes can range from 1 to 10 individuals and should not exceed 10 individuals. Next slide. So when we talk about the scope and intensity of PSR, many people think about the daily unit limits that were on the rate sheet or still are on the rate sheet for BH HCBS. And that limited you to, I believe, 8 units a day for PSR. What we've done is we've removed the unit limits. So there's nothing that's going to be like hardwired into anyone's system that would prevent you from going over that. We've also removed the per diem rate code, the 12 unit equivalent, I believe the rate code was. I'm sorry, I just realized my hand was raised. That was distracting me. So we've removed the per diem rate code, and what we have instead are recommended unit ranges. So we looked at PSR and said, how much of this service do we think someone should receive on any given day? Like, what is the range that we might prescribe? So on the next slide, I'm going to show you this chart. For individual sessions, we look at a range of anywhere from 1 to 12 units a day. So that's anywhere from 15 minutes up to 3 hours a day. would be appropriate. You would just need to have that, documented in the person's individual service plan. For a group, the groups are much shorter. We're looking at 1 to 4 units a day, so 15 to 60 minutes. And this likely means that someone would probably only receive about 1 group a day. If they were receiving PSR in that modality. If you're looking at someone who needs a lot more groups than that, there may be a better level of service or level of care for them in the behavioral health system. Next slide. These ranges can be exceeded if you have a crisis situation. So in that case, you can go ahead and provide over the 12 units in order to support the person through that situation, stabilize them, figure out if they need another level of care, if they need a mobile crisis team or an emergency room visit, something like that. So you can exceed the 12 units in the event of an emergency or a crisis. You just need to make sure that that's clearly documented in a progress note. What we wouldn't want is to come out in an oversight and monitoring situation and we're reading progress notes and we see that you were with someone for 5 hours and it's unclear why. It's not in the ISP. The chart doesn't indicate that there's any kind of a crisis. That would be concerning to us. So just make sure that you're clearly documenting. The other time when you might exceed the range is when a short-term increase in intensity would support goal acquisition. So maybe in the example of an individual who's going back to school in the fall and they've been engaging perhaps in a group focused on time management, and then they're getting some one-on-one services that'll help them with all of the enrollment paperwork and requesting reasonable accommodations at school. Maybe in the week or 2 before school starts, they really need a much higher intensity. They're buying school supplies, they're getting their folders organized, they're, adding and dropping classes. And so a higher intensity for that short critical period of time means that they're going to be more successful with their goal. That would be acceptable. What we'd like to see is that you are documenting that decision and that the decision be made in consultation with the clinical supervisor. This is one of the reasons why we're really happy to have a clinical supervisor for PSR. We want to see that they are being consulted and that their clinical expertise is being used and that the documentation matches up to that. All right, next slide. PSR services are not case management, they're not personal care, and they are not a replacement for custodial care in an institutional setting. What we mean by that is you're not everything to this person. PSR is not intended to meet all of a person's needs. It is intended to help people restore their functioning and increase their supports so that they can move forward towards their recovery goal. We want to promote independence. We want to use skill building. We want to develop those community resources and supports. But if someone needs a case manager, they should have a case manager. That's not you. If they need personal care services, if they're really needing support with their ADLs, then they should be referred to a personal care service or a home health service. That is not on the PSR worker. And if they need a higher level of residential care, if they are really in need of residential services, again, they should be referred to that level of service. PSR is not intended to provide supervision or anything of that sort. It's not a replacement for residential services. All right, next slide. I'm just going to walk you through a brief case example. I'll try to briefly summarize everything, and then we'll use the rest of our time today to try to answer the questions, which I see the chat box has been pretty busy while we're presenting. So I'll start with a case example on the next slide. So Sean is a 35-year-old man living in a community residence with 7 other adults. He's very motivated to work and earn extra money. He enjoys going out for coffee and socializing with friends, but he's limited by his budget and the money he receives in his personal care allowance. He has a high school diploma and a sporadic work history, generally in fast food and janitorial settings, and he doesn't really enjoy that. He is anxious to work, but he's really concerned about losing his benefits. It took a long time for him to get those benefits established. He's happy with the level of support that he's receiving, and he doesn't want to lose those things if he gets a job. He also wants to make sure that he could get a job somewhere where he can walk or where he can access independently. The housing staff are reporting that he struggles with his hygiene and ability to remember appointments. Next slide. The housing staff make a referral to core PSR because they feel like the psychosocial rehab staff might be able to provide an added boost that they just can't do in the housing setting. So the core PSR staff meets with Sean to gather information about his goals and what his preferences are around work, what his strengths are, and what the barriers are, why it is that he hasn't been able to achieve this goal on his own. With his consent, the PSR provider is also able to talk to his clinical providers, and that really informs the intake and assessment process so that they can develop a thorough ISP. Staff first work with Sean to help him understand how work might impact his SSI and other benefits. So that's going to be key because, as I mentioned earlier, he was concerned about losing those benefits. He's not going to be successful in that work setting if we don't figure out what the impact will be first. So this meant that the PSR provider supported him in meeting with the fiscal coordinator at his housing agency to determine how much money he can earn before incurring a spend down. All right, next slide. The PSR staff then worked with Sean to help him use public transportation so that they could expand that search for work outside of the walking radius. And they began looking for jobs that were accessible to him by bus. This helped Sean see what types of jobs were available in the community. And it helped the PSR provider to better refine his preferences and really figure out what it is that's going to be motivating for him. He didn't like the fast food and janitorial work, so what are some other options? This also helps them to find employment that's going to match his skills. The staff address his job readiness through hygiene, working on interview skills, and addressing barriers related to time management. So if you recall, those were brought up by the housing provider as areas of concern. And Sean's able to apply for several jobs in the community. He's eventually hired at a local bookstore where he unpacks new books and stocks shelves. All right, next slide. So why did PSR work in Sean's case? Number one, his preferences around work were respected. So he said he didn't want fast food and janitorial work, and the PSR provider was very flexible, showed him different settings, brought him out into the community, and found something that would work based on his preferences and his strengths. There was a rapid job search process that was utilized. So as staff become familiar with the IPS model, they'll learn that it's best to make sure that we start a rapid job search when someone is interested in employment. We don't want to get them trapped into a pre-vocational cycle where we feel like they just need to build skills, and they never actually get the job. So we started looking for a job for Sean very quickly after he expressed interest. And the skill development piece was wrapped around that job search. They were able to address the behavioral health barriers that would have impeded successful employment by focusing on jobs that he was motivated to pursue. They were also able to work on things like navigating the community, riding the bus, addressing his hygiene concerns, and working on time management. And then lastly, they also incorporated the benefits counseling piece because this is a huge barrier to many individuals with work goals. They want to make sure that they are aware of what the impact might be on their benefits. If you as a PSR provider don't feel qualified to do the benefits counseling piece, that's okay. You just need to make sure that you're connecting people to the resources in the community where they can get this. In our case example, that was a fiscal coordinator at the housing provider, but it might also be something like a one-stop center out in the community operated by DOL, or there may be someone else in your organization that does benefits counseling. So we would just encourage you to make those connections. All right, last slide. So I know that we've gone over a lot of content today, and I see that there are some very detailed questions in the chat box. I'll just try to summarize and then we'll get over to questions. So PSR is an a la carte rehabilitation service that can be provided alone or as part of a customized service package. So many people might only need PSR. They may not need or want the other core services, and that's okay. You can deliver it individually. You could also deliver it as part of a bundle. So maybe someone, in our case example, if Sean had wanted someone to work with his family to understand what the impact of his work might be on his benefits, that is something that could be done under family support and training. So you're going to look at each individual and make a person-centered decision about which services are right. And you're going to coordinate with the LPHA to make sure that you have that medical necessity documented. PSR interventions focus on restoring functioning and developing supports. So it's all about making sure that we're helping people be independent and that we're getting them the resources they need in order to maintain that independence in the community. Individuals are supported in choosing, getting, and keeping valued life roles where they live, work, learn, and socialize. We also have an enhanced rate available to support training and evidence-based practices related to employment and education goals. So if someone has an identified employment or education goal and you're providing PSR interventions in support of that goal, there is a slightly higher rate that you're able to bill for that work. And that's because of the enhanced training requirements we have. So we know it takes more time from your staff to get the training and to be well versed in those interventions. And we want to respect that with a slightly higher rate. So I would encourage you, if you have questions around that piece, to make sure that you've read the operations manual and the benefit and billing guidance. And with that, I think we can go to the next slide and start answering some questions.
Thank you, Katie. Thank you, Steve. So I have been collecting all the questions that have come in and comments. So thank you to everyone. I want to encourage folks, if you do have more, to continue chatting them in. I have a couple that I'm going to start with, and we will be getting through as many as we can. Please know that if we don't address your question today, the state will still receive it. We send all of the comments and questions that do come in during our webinars back to the state. So they will be seeing everything, whether or not we can address it on the webinar today. All right, so for our first question, this is kind of a question about the comparison between adult BH HCBS vocational versus core PSR with a vocational focus. And someone's wondering if you can define the difference of what the goal is between both.
Yeah, so the goal could be the exact same. If someone says, I want to get a job, that could be an appropriate goal for PSR with an employment focus. It could also be an appropriate goal for BH HCBS, intensive supported employment. It could be an appropriate goal for PROS or for clinic or for ACT. I mean, the goal itself isn't going to change. What changes is the level of support that an individual needs. So if they feel, and the LPHA agrees and the provider agrees, that psychosocial rehabilitation isn't intense enough and the level of service that they need to meet that goal of I want a job, then it's the right service. So the goal itself doesn't change. What does change is you're looking at the person's barriers, you're looking at their strengths, you're looking at their environment and what level of support they are going to need in order to achieve that goal. That's really the difference.
And kind of on the same level, Katie, this is now about the difference between education under adult BH HCBS and PSR with an emphasis on education. I think some folks were just wondering if you could clarify that a little bit.
Sure. Steve, do you want to try answering that one or do you want me to?
Sure. Well, I think I saw that question came in and just kind of thinking about it. Again, PSR within education support or with an education focus, you're really focusing on skill development and overcoming barriers. So when I think about supported education, there's a number of interventions that I would call, I call them, just for myself, doing for interventions. And that's things like note taking. So this is something someone in that supported education model, the staff person can take notes for someone, or they can read to someone. There's some advocacy involved that the staff person can work with the school faculty, things like that. So again, I always hold on to the note-taking example, but this is something that you are doing for the person rather than teaching skills. So I think that's the real difference. Does the intervention sort of fall into that rehab counseling realm of overcoming barriers, teaching skills, things like that? So that's how I conceptualize it.
Thank you, Steve. So I'm going to jump to a different topic. So I think this was about staff qualifications, and there was a question about the requirement to have a bachelor's degree. And so someone's wondering if we can clarify whether that's a bachelor's degree in any field or a specific field, if the state's able to clarify that.
Any field.
Any field. Okay, thank you.
Mhm.
All right. So with the required trainings, is this only applicable for unlicensed staff, or is it for all staff, including clinical staff?
The required trainings are for all staff and all supervisors. It has nothing to do with what degree or background you have. The idea is that we want all staff to start from the same place, and we want all supervisors to know what training their staff are receiving and to be also approaching services from the same lens.
Great. I'm going to go through a couple more questions that are related to training. I do know, and Katie and Steve, you can probably add more detail to this, that there is a training memo the state is finalizing that may answer some of the following questions, but I'll raise them. And Katie and Steve, if you want to refer people to the soon to be finalized training memo, great, but I'll just raise them now in case. So people are wondering, one, if the trainings that were referenced today, will they all be available on the CPI LMS?
Yes.
Okay. And are those, in terms of like the timing of when staff should start to review these trainings, is it now? Should they wait until closer to go live? What is there a recommendation from the state around this?
We are actually working on those trainings right now. Some of them are already in the CPI system under HCBS, adult BH HCBS, but we're working on right now, I'll call it a training track for core. So we anticipate everything's going to be ready to roll, right around the core implementation date of February 1st.
Okay, thank you. All right. Okay, and then more specifically, this is a little bit more detailed question about the training piece and staff and the timing. Is it going to be required that all staff have completed all 6 training modules before they can provide the services? Or will there be kind of like a phase-in period to complete them while providing the services?
Well, we have outlined a period of provisional designation, which is the first 6 months of core implementation. Certainly we would suggest that staff try to get those trainings completed as soon as possible, especially those service specific trainings. But I don't know if you have anything to add, Katie, about that.
No, I think that the staff training memo will be out shortly and should explain all of that, but there will be, you will have time to complete them. It's not like on February 1, everyone needs everything done.
Got it. Okay, thank you. And then this is one more detailed question about training. A couple folks chatted in, they were wondering if, who will be providing or where will people be able to receive training on cognitive remediation?
So as of today, the state does not provide training in cognitive remediation. Cognitive remediation, when done in an evidence-based way, typically involves the use of a curriculum and often software that needs to be purchased. So that would be an agency by agency decision, which model you want to adopt and how many staff you're going to train. There is a cost associated with it. And unfortunately, that's not something that the state is able to cover at this time. So if you're interested in offering that specific intervention, we would just encourage you to do some research. If you're really stuck and you're like, I don't even know which types of programs to Google or look for, then you can always shoot us an email and we'll direct you to some resources, but it is not something that the state provides or funds.
Thanks, Katie. Okay, I'm gonna move off of training for the moment. We got a question. Folks are wondering, will there be guidance for MCOs to ensure that they interpret unit ranges in the same way that the state is outlining them?
So the MCOs have all of the same guidance that you have. I mean, they have a couple additional pieces, but they have the operations manual, they have the benefit and billing guidance. We have spoken to them about this. So if February comes and there's any different interpretations happening and you're having any issues with billing or claiming, we would strongly recommend that you reach out to our managed care mailbox, and we will provide technical assistance and support through that. But the MCOs have the operations manual. They're getting the same guidance that you're getting.
Great. Okay, so this is some questions about telehealth. Folks are wondering if CORE allows a telehealth service and a face-to-face service for PSR to be delivered within the same day.
Yes.
Yes, okay. And does the state have an update? I know this is broader than CORE, Katie, so that we might not be able to answer this. But I think some folks were chatting in and understanding that telehealth was going to be ending, the provision was going to be ending soon, this month. Is that the case, or are we able to speak to kind of the telehealth with CORE as of February, and if it will be available?
I am not going to get ahead of our commissioner in terms of what waivers are happening and expiration dates. What I can say is I feel very confident that telehealth will play a role in CORE services. We are still in the middle of the COVID-19 pandemic, and the state is very sensitive to that. And we have also reassured all of our providers that we're not going to pull the rug out from under anyone. So if and when telehealth flexibilities are ending, we will give as much advance notice as possible.
Thank you. Okay, so this is a question about clinical supervision. And wondering what it looks like in terms of the documentation piece, the kind of staff plan, what needs to be submitted, and also wondering if group supervision is allowed.
Group supervision is allowed, but you do need to make sure that each individual staff person still has access to that clinical supervisor. So what we've seen is some agencies will hire a clinical supervisor to come in and do 1 hour of group supervision a week, and all of the staff attend that hour. But if they need anything outside of that, say it's 4 o'clock on a Thursday and they have a client in crisis and they need someone to call, that supervisor may not be available if that's the arrangement that the agency made. You need to make sure that your clinical supervisor is available to staff for individual consultations as needed. So group supervision is definitely allowed as long as you have that availability for the individual piece. Supervision does not need to be documented. We're never going to ask to see like supervision logs. If you have them, they might be helpful and you can show them to us, but it's not an expectation. How we determine whether or not you're meeting our standards is we talk to your staff, we talk to your supervisors, we look at the progress notes. If the progress notes never indicate any sort of communication with a clinical supervisor, but you were regularly exceeding recommended unit ranges, that would be a concern. If we interview your staff and they say, I didn't even know I had a clinical supervisor, which by the way is a thing that's happened, that's a problem. That's where you start running into issues. So we want to give agencies the freedom to set their own policies and procedures. We're not going to look at your clinical supervision logs or anything like that, but you need to make sure it's happening.
Thanks, Katie. Another question kind of tying back to the rates. So folks are wondering, has there been an increase, excuse me, in the rates for CORE compared to HCBS?
So there's a lot going on with the enhanced federal matching funds that we have right now. And I don't think I can fully answer this question in detail right now. What I will say is that any rate increases that are temporarily happening as a result of FMAP would apply to BH HCBS and CORE. So it's not like CORE is getting anything that HCBS isn't getting. But the exact numbers and what that looks like and for how long a rate increase might be available, that's all forthcoming.
Okay, thank you. So someone chatted in about congregate housing and CORE. Will this be allowable to serve an individual with CORE services who also might be engaged in congregate housing?
Yeah, that's actually one of the really exciting things about CORE is that we are not under the HCBS final rule. So individuals who reside in congregate settings can receive these services, with the only exception being individuals who are in institutions for mental disease or IMDs which is something defined by the federal government, they would be excluded, but that's a very small subset of the individuals who live in congregate settings in New York State.
Great. Thanks, Katie. Okay, let's see here. Okay, so this is a question about transitioning clients from HCBS to core. Should the transition of clients from adult BH HCBS to core PSR services be completed by February 1st or be facilitated over those first 3 months of the provisional designation?
Yep, so this is detailed in the benefit and billing guidance, and you have the 3-month period to transition people. I would really recommend taking a staggered approach, because if you try to do everyone on February 1st, or if you try to do everyone on May 1st, all of your ISPs are going to continuously come due at the same time, which is not what anyone wants. So we're giving you 3 months. Please maximize that 3 months, figure out who you might transition first and who might need a little bit of more time. The way you transition someone is you update their ISP. The ISP does need to conform with the core services documentation requirements. So it needs to include all of those form fields, and you make sure that it aligns with the core service definitions and components. And once you have that, once the individual is like, yeah, this is what I want to do, this is how I want to receive core PSR, and the service plan is done, then you're going to notify the MCO using the service initiation form that that individual has successfully transitioned. That piece is important, because if an MCO finds that it's May 3rd, the 3 months is up, and 40% of people haven't transitioned over, that would be a huge issue, and they'll probably get the state involved. So we don't expect that issue to happen, but we just want the MCOs to be aware when each of their members has successfully transitioned, so that if there is a need for any follow-up, we can coordinate that with them.
Great, thank you. So a specific question for PSR with an educational focus: would it fit within that core service to teach a person to read? Does that fit under PSR with an educational focus?
I would say no. That sounds like an educational service that should be provided by someone who has some expertise or training in teaching individuals to read. It doesn't sound like you're restoring functioning due to a mental health diagnosis or an addiction disorder. So if you're not restoring functioning related to a behavioral health disorder, then you're not providing PSR. So I would say teaching someone to read is probably not appropriate. But if someone has literacy challenges, perhaps they have dyslexia and it went untreated in their youth, I would really strongly recommend using PSR to successfully connect them with a tutoring service or an educational service in the community, at like a local EOC. And if they have any behavioral health barriers in that setting, if they're experiencing anxiety or time management concerns, that is something that you could address through PSR to make sure that they're successful in that educational setting.
Thank you. Kind of along the same lines, just to follow up about what fits and what doesn't. What about PSR for an individual who is interested in socializing, but not necessarily an education or employment kind of goal area?
Yeah, no, living goals. So where you live, how you maintain your household, and social goals related to, building friendships or strengthening family relationships or finding volunteer opportunities. Those are all very, very valuable PSR goals. I don't ever want anyone to think that it's all education and work all the time. We know that loneliness and social isolation is one of the biggest social determinants of mental health. And so we want to make sure that PSR is used to address those things. So absolutely, please do use PSR. Use the rehab counseling and the skill building to support individuals with living and socializing goals. The only big difference here, number one, is that staff don't have to be trained in things like IPS if they're supporting a living or socializing goal. And the rate is just the normal PSR rate. You don't get that, I think it's about a $1 enhancement for an education or employment goal.
Great, thank you. Again, just another qualifying question for PSR. Can individuals receive both PSR as well as services from Access VR for employment or education?
So I'm going to say yes with some caveats. I actually think that there's a really nice opportunity for PSR to be delivered to individuals receiving Access VR services, because Access VR doesn't always address the behavioral health barriers to employment and school. They're not necessarily as skilled in working with our population, so they may not. They may be really good at paying someone's tuition and helping them get reasonable accommodations at school, but they may not be so great at training people in study skills, or managing anxiety when talking to peers at school or something like that. So I do think that these services can go hand in hand. What you want to be really careful around is duplication of services. So just make sure that the right hand knows what the left hand is doing. If you share your ISP with the Access VR provider, they might share their individualized education and employment plan with you, so you can both look and see what interventions are being offered, and just ensuring that there's no duplication of services. So yeah, Access VR is compatible with CORE.
Thank you. All right. One of our most recent questions that came in was regarding the IMD exclusion. Will CORE services be able to be provided in congregate housing programs operated by voluntary agencies, but located on the grounds of state psychiatric centers?
So I would really encourage this individual to reach out if they're thinking of a specific CR or congregate setting. There is no exclusion around the grounds of a state psych center in the same way that there is for BH HCBS. So many people are aware that because of the final rule, the settings rule, you can't deliver any BH HCBS on the grounds of or adjacent to a psych center. We don't have that same rule. But if a CR on the grounds of a psych center happens to be classified as an IMD, which is not all of them, but some of them, then we may have an issue. So please just, if you have like really specific questions about a setting, just reach out to us and we can let you know.
Great. Okay. Next question. Is it required that PSR counselors see their client's living environment?
It is not required. It's not required.
Thanks. Thank you, Katie. Okay. This is kind of tied back to the question we just answered a little bit. Someone is wondering if CORE can be provided while individuals are in an inpatient setting.
We're working with our counsel's office on guidance related to this, so I'm going to ask that you hold off. We just released our FAQ yesterday, and we're working on a second FAQ right now. That question is on there, and I just want to make sure that I get the language exactly right. So to be answered later.
And judging by the number of questions we're getting, Katie, you're probably going to have another FAQ.
Yes.
All right. Okay, so another question that came in. If you're looking at socialization or living goals, would it be more appropriate to utilize PSR or EMP services?
By EMP, I think that they're talking about empowerment peer support. Yep. I would say it is 100% dependent on the individual's preferences for how they would like to receive services and the recommendation of the licensed practitioner of the healing arts. So both peer support and psychosocial rehab can be used to support individuals with goals related to socializing and living. But it depends. Does that person want to receive services from someone through the lens of shared personal experience, or would they like a more restorative level service like PSR? It's really going to be based on preferences and needs as assessed by the LPHA.
Great. Thank you. All right. So I know we're winding down our time. I do want to encourage folks to continue chatting in their questions. We had two questions that came in earlier that I'll raise. I'm not sure if we can address on the call this morning on this webinar, but this is again about, this one is about training, and if the state has a recommendation around rehab counseling trainings that an organization would like to incorporate into their training program for a staff. Is that something folks should follow up directly with the state on? Or I'm not sure if that's something you could speak to right now, Katie.
Yeah, so rehabilitation counseling, which is essentially psychosocial rehabilitation, there's a lot of training resources on this. It depends on where your agency is. If you're downstate, I would strongly recommend checking out the Center for Rehab and Recovery at the Coalition for Behavioral Health. NYAPers, some people may not know what that acronym is. It's the New York Association for Providers of Psychiatric Rehabilitation Services. NYAPers provides a lot of training on psych rehab and rehab counseling skills. There are some modules in CPI's LMS that are available for free for any BH HCBS or core providers. And the state is actually currently working on developing additional training resources in this area. So stay tuned to the listserv for that. If you're looking for more specifics, again, you can always email us and we'll try to point you in the right direction.
Thanks, Katie. So at this point, I think that we've addressed the majority of the questions that have come in. I'm asking, if there's any outstanding question that folks still have in the remaining time, to please don't hesitate to chat it in. Just as a reminder, this webinar is recorded, and the recording along with the slides will be shared, hopefully by the end of this week is our goal. And also, I believe my colleague Tara, who is our MCTAC admin, as well as our state partners on the line, have been chatting out links to a lot of the materials and resources that Katie and Steve have referenced throughout the presentation. So if you haven't had a chance yet, I would encourage you to copy and paste those, plug them into an email so you can revisit them. And Katie and Steve, I'm curious if there's anything else you want to highlight or emphasize as we start to wind down and end the webinar.
Just a reminder that the FAQs came out yesterday, so please read through them. And if you have additional questions, we are developing version 2 that we are targeting for release in January. So please keep sending us your questions, keep attending these webinars. And if there are additional areas for training that would be helpful as we move towards February 1st, please let us know.
Okay. And we do have 2 more questions.
I'm sure.
So wondering if the links that were provided, I'm sorry, a lot of questions. I lost track. So should we be using the links if we are providing services to youth? So I think this is someone who's wondering if they should refer to the resources that were circulated if they are providing services to youth.
So core services are only available to adults 21 and over because we're targeting the HARP population and the HARP eligible HIV SNP population. So this is adults 21 and over. If you're working with children and youth, I believe you would need to check out CFTSS and Children's HCBS training resources.
Thank you. 2 things that I think I can help address. So there was a question about how to become designated to provide core services if you're not a designated HCBS provider currently. Katie, I believe there's going to be information forthcoming from the state. It might not be available right now, but should providers stay tuned for that information if they're looking to become a core provider?
Yep. Just stay tuned. We are working on that right now. Our database that many of you are familiar with for BH HCBS hasn't yet fully been updated. We're working with ITS on that. So as of today, we can't accept applications, but stay tuned.
Okay. A clarification around the training piece for staff. Did the state say that clinical staff must complete all core trainings that staff and supervisors are required to do?
The clinical supervisor, which is the only required supervisor by New York State, must complete the required trainings. The staff providing the service must also complete them.
Wonderful. Thank you. Another question. So someone is asking about a link to the terms that were used for things in acronym form, such as PSR and ISP. Katie, if I'm not mistaken, I believe when I read the FAQ that was just circulated yesterday, there's a lovely table at the top that kind of breaks down the different acronyms. Is that correct?
Yeah, the FAQ, we included any acronyms that were in the FAQ document itself. And in our operations manual, in the appendix, we actually have a glossary with acronyms. So I would point you to the operations manual and the FAQ.
Wonderful. Okay, I'm going to try and get to these last few questions. If you are wondering if slides are going to be shared, they will be along with the recording from today, hopefully by the end of this week. So you can review all the content and share this with your colleagues. Someone is wondering if physical health wellness be identified as a goal for PSR, as in addressing mental health barriers that impact physical health for the purpose of promoting restoration of independent functioning?
I couldn't have said it better myself. Yes, 100% yes. And I love that caveat that you are addressing mental health or addiction barriers that impact physical health. Absolutely. I would categorize that under living personally, but yes.
Great, thank you.
Mhm.
Okay, let me just scan. Katie, are the FAQs also posted to the centralized kind of OMH core website? Is that where folks can find them if they're not on the listserv yet?
The FAQs will be posted on our website within the next couple of days.
Great. And for the folks asking about when the anticipated release date is for the staff training memo, I believe the state is working very hard to get that out as soon as possible. So Katie, I don't know if you have an identified date, but I know you're working on that.
As soon as possible and definitely before February 1st, which by the way, the trainings may not be available until, January 30th. So I wouldn't,
Yes.
memo's not helpful without those anyway.
Okay, perfect. Okay, let's see here. So someone is also wondering if it's appropriate for a core staff person to be part of a discharge planning team from hospitals if a participant is already active in core.
Yes, 100% yes.
Great. Okay. All right. So I think with that, unless Katie and Steve, you have anything else to add? I think those.
There's a question around restoration of skills and whether PSR can be used to support the development of new skills. So I think it's important that we respect the fact that we do still have BH HCBS habilitation, which is around the development of new skills. So we do have some distinction there. I would just offer the caveat that PSR focuses on restoring functioning. So if what you're doing is teaching a new skill to restore previous functioning, then that is PSR. But if you're adding on functioning that the person never had and teaching brand new skills that the person never learned, perhaps for a developmental reason, that would be more habilitative in nature. So if there are additional questions around PSR versus HAB, I would encourage people to send them to us in the mailbox. I think that is all of them.
I think so. All right. Well, thank you, Katie. Thank you, Steve. And thank you everyone who joined us and, chatted in your questions. I always find that not only is the material our state partners review incredibly helpful, but it really helps, I think, us to really think through the details and nuances of how this gets implemented with your questions. So I want to thank you all for chatting in your questions and joining us this morning. Take care and have a wonderful day.
Thank you.
Thank you.